So, if you've recovered from that bit of a lecture, I will be happy to cover some questions. We have a few that have been called in ahead of time or phoned in ahead of time, and I'll go through some of these. I think they're illustrative. One from a patient in Danville, Virginia, who said, I read somewhere that the addition of radiation for DCIS has been shown in clinical trials to reduce local recurrence risk, but has not been demonstrated to prolong survival. I don't understand how that can be true. Could you explain? Well, of course, as we said earlier, DCIS is not a life-threatening disease. So in fact, the biggest concern we have is when a patient recurs, if they recur with invasive disease. Of course, for that invasive disease to result in a mortality, you have to expect that the disease occurs, develops, and grows fast enough and far enough that it's not detected until either microscopic or clinically detectable metastasis or spread to other parts of the body occurs. Since these women tend to be followed anyway after they've had disease, most of them are rescued with recurrence by appropriate operative intervention, such as a new lumpectomy and radiation, or even mastectomy. So the number of women who would actually progress far enough after developing an invasive recurrence to develop the true life-threatening disease just doesn't seem to be large enough to budge the statistics. Again, that doesn't mean that we should think of a local recurrence of invasive disease as a minor issue, because it does involve major therapeutic interventions, which are both unpleasant and costly, and we should try to avoid. Someone wrote in from Los Angeles, not far from where I live. Is Oncotype commonly used for patients with DCIS, or is it still too new? Well, clearly this test is a relatively new test. It was first presented publicly at a major scientific meeting in early December of 2011, and the test became commercially available at the end of that month. Now, that doesn't leave a lot of time, and physicians tend to be conservative in adopting new approaches. But over 1,000 of these tests have been done so far, and this test can have a very profound effect on decision-making as long as both patients and physicians understand the strengths and weaknesses and understand the circumstances in which the test was developed and validated, so that an individual patient's circumstance reasonably matches that of the original patient set. For example, the study that we quoted in the discussion earlier included individuals who had tumors removed that were DCIS with margins of 3 millimeters or greater. So running the Oncotype test in an individual such as that, with 3 or 5 or 10 millimeters of margin of healthy tissue around the tumor, would be perfectly reasonable in trying to make an assessment of whether or not to proceed with radiation, as an example, because a recurrence risk is acceptable or not. But it might be a little more difficult to make an inference if a woman in question had a margin of only 1 millimeter or 0.5 millimeter, or had a cancer cell touching the cut surface of the tumor, because that wasn't the population in which the test was developed in. And while the test may have validity for that group as well, we just don't have enough information to state what the differences would be. One of the individuals who's a participant in this conversation from Colliersville, Tennessee, wrote, "Can you have ductal carcinoma in situ and invasive ductal carcinoma in the same breast at the same time?" And the answer, of course, is yes. Often when we see patients who have invasive ductal cancer, we will also find foci, or individual focus points within the tumor or within the breast, of DCIS. These are often adjacent, and of course are one of the reasons that we think of DCIS as a precursor lesion, and one that can give rise to and develop into invasive disease. Also, of course, the issue of recurrence risk, which we've discussed before, would suggest that if, in fact, some of the recurrences after inadequately treated DCIS are invasive, that again, DCIS may be a precursor. But we really don't believe that all DCIS is a precursor. And unfortunately, we don't really have good tools to let us know which DCIS is really a risk marker, which is a kind of local bothersome issue because it creates difficult to read and follow mammograms, and which DCIS is actually the kind of DCIS that's going to continue growing into a cancer, much like colon polyps do. So in this setting, I think it's important to note that, yes, DCIS can occur with invasive disease. However, when this does occur, we don't focus so much on the DCIS treatment because, after all, the disease that is the highest risk is the one that demands our attention. And it's the invasive component that will determine our therapeutic decision-making and ultimately the choices that the patient will proceed with. A patient from Canadensis, Pennsylvania writes and says, is it possible to say that when having breast-conserving surgery, we're relatively safe from having cancer further along in the same duct? Well, this, of course, is a concern, and it's probably a bigger concern with DCIS than any disease because this disease tends to grow more along the ducts than invasive disease does, which tends to grow, at least when it's ductal cancer, in a tight ball with maybe some star-like extensions. But in fact, everything we've shown you today is the endpoint answer. It takes into account the fact that disease may spread along the ducts. Certainly with modern high-resolution studies, such as the ability to utilize digital mammography, and in some circumstances MRI, which can help us see the extent of DCIS, we should be able to guide surgeons like myself to remove the appropriate amount of tissue that includes the extension of the DCIS. Now, that isn't possible all the time because, of course, when we're operating, we see a field of yellow fat. We don't see the calcifications, and we depend upon assistance of our radiology colleagues to put in markers to help us distinguish the ultimate likely margins. And we try to thread the needle between going too broad and removing unnecessary healthy breast tissue and getting too close and leaving a positive margin. But that does remain the challenge. And of course, it is the basis of using radiation therapy, which sort of mops up cells that may be left behind. The good news is that patients with low recurrence risk in a large prospective study run by the Eastern Cooperative Oncology Group that formed the basis of the validation took women and did not give them radiation as long as they had clinically 3 mm clear margins and met certain criteria regarding size and grade of tumor. And the fact is the recurrence rates were very, very low when these patients had a low recurrence score as measured by the gene expression assay of Oncotype. So I think we have good endpoint information, but at the end of the day, surgeons still need to be very careful. Technique is very important, and we need to make sure that we don't overextend our indications for using any test or drawing any conclusions. Someone just called in and said, I had DCIS 6 months ago. Is the Oncotype test something I could still do? Well, of course, the nice thing about the Oncotype test is since it's run on formalin-fixed and paraffin or wax-embedded tumor, which is how tumor is stored at all institutions, it means that the test could be run 6 months after the DCIS. It could be run 6 years after the DCIS or 16 years after the DCIS. So the question isn't whether the test can be run. The real question is what is the practical value of the test? If it's simply to get a score that says, this is what my risk is, gee, isn't that nice? And had I known this 6 months ago, I would have made a different decision, then it's probably not a good idea. It's not a good idea because, number one, it's quite expensive test, and it would be hard for one to justify that to a payer that it's worth spending thousands of dollars to do a test in which there's going to be no change in therapeutic intervention. On the other hand, if the individual who sent this in has not had any treatment since the surgical lumpectomy and is still toying with the idea of whether they should or shouldn't have radiation, and they have not received any hormonal therapy, then I suppose the test may have a reasonably valid role. Of course, keep in mind that most of the studies that showed the value of radiation showed that radiation value when the radiation was utilized within about 8 weeks of surgery. Doesn't mean it couldn't be a value 6 months out. We just, again, don't have large studies with that information. But this is something to talk to your physician about if indeed no treatment has been given other than surgery. Now, there was another question which I think is interesting because it shows the mixing of some information that has been in the news, which many cancer patients are aware of, and that is the issue of HER2. A writer from White Plains, New York says, I was diagnosed with DCIS 4 years ago. I had lumpectomy, radiation, and chemotherapy with Herceptin for HER2-positive disease. You don't mention chemotherapy as part of the treatment. Now, I would suggest that perhaps the individual writing in may not have heard or appreciate all of the information in their pathology. There is no role for traditional chemotherapy in the management of DCIS. And there is no approved role at this time for Herceptin, or an antibody that blocks the activity of the HER2 protein in DCIS. HER2 is a protein that sits on the surface of some cancer cells, about 20% of invasive cancers, and acts as a sensor, if you will, for the cell. It tells the cell kind of what's going on in the outside world and acts as a signal amplifier. It actually helps the cell's sensory mechanism, if you will, become more robust and send messages to grow onto the nucleus or control center of the cell. And so if in fact people have overexpression of HER2 in their tumor cells may grow faster and be more challenging to manage and have poorer outcomes with invasive disease. So in fact, one of the great advances in oncology over the last decade has been a drug, trastuzumab is the generic term, or the brand name Herceptin, that is designed to interfere with this process, the signal transduction process. And in fact, trastuzumab can reduce the risk of recurrence of invasive disease and the very worst of invasive disease by about half. Well, what about in DCIS? It turns out that there are a significant percentage of DCIS cells that also overexpress HER2, the same protein. Well, is there any role for treating that? Well, we don't know is the answer. It turns out that HER2 may be important as cells are evolving or developing or perhaps even transforming from non-invasive to invasive disease. There just isn't enough data to answer that question exactly. There is a large clinical trial that's been underway, started by the NSABP, that looked actually at whether or not interfering with the HER2 mechanism may help patients and reduce local recurrence when combined with radiation therapy. But this is a trial in which there is no data available at this time, and certainly this should not be considered a standard of care. Bottom line, there is no role for chemotherapy in true, strict duct carcinoma in situ, and 2, there is no role for the use of Herceptin in this disease at this time. Another individual writes in saying, is microinvasive ductal carcinoma threatening? This from Lake Butler, Florida. Well, microinvasive ductal cancer is when somebody has duct carcinoma in situ and the pathologist looks over several sections and finds an area where the disease no longer seems to be confined to the duct. They don't see a large area of disease that is extending. It's not a bulky tumor or even a microscopic solid large nest of cells, but perhaps an area where the integrity of the scaffold or basement membrane around the duct has disappeared, and you now see 5 or 10 or 50 cells that have kind of collected in a little area outside the duct. By definition, this is invasion. but it's very small, so it's called microinvasive. Of course, at the end of the day, we don't know for any given tumor how many cells it takes to reach a lymph channel or a blood vessel and invade and travel to another part of the body and survive. But we have a lot of studies over the years with a lot of inference that suggests that tumor cells not invariably enter our circulation if we have a primary malignancy, but that it's an extremely rare and difficult event for those tumor cells to actually survive, grow out through the blood vessel, implant into surrounding tissues, develop their own blood supply, and thrive. It's a hostile world out there. And in fact, we know again from many, many studies over the years that we can find circulating tumor cells, but the vast majority of these never actually become implanted tumors. So in the case of microinvasion, is there enough activity going on to present a risk? The answer is, of course, if there's invasion, there's a potential life threat risk. Does that mean these individuals need to be treated with full course chemotherapy and a lot of aggressive concern? And I think the answer is no. For the most part, these are likely to be extremely small. They're classified in our current staging system as T1A, which is the smallest class there is of classification of tumors. And we know the T1A disease, while it is possible to have distant disease, is extremely uncommon. So the answer is a qualified, very little life risk threat. A writer from Rockland, California writes, and can I get DCIS in the same breast again? And does this mean I cannot have radiation in the same breast? And I think that's a great question because, of course, you can get any kind of breast cancer in a breast more than once if you have a breast. So breast conservation, of course, raises the question of not only recurrence, true recurrence, i.e. disease that has arisen from the prior disease that was there, but of course suggests in individuals, particularly if they have other elevated risk factors, including genetic risks for breast cancer, that they can in fact get another cancer in some number of years, whether it's 2, 10, or 15, or 20. And unfortunately, once breast conservation has been utilized and radiation therapy has been utilized, it becomes very difficult to use breast conservation and radiation therapy again. Now, it's not impossible, and certainly there are a number of studies, including a moderate-sized one from the University of Pittsburgh that suggested that patients can, in fact, have relumpectomy and radiation, but the cosmetic outcome is really quite poor, I think, by any independent evaluation. And what is left at the end of the day is not likely so much to be a breast as a kind of firm bump that is probably not very appealing. So it would clearly be advantageous to avoid radiation in individuals who have relatively low risks of recurrence, because if indeed radiation has not been utilized and they do develop a second cancer in that breast, invasive or non-invasive, in 10 years, that individual is still a full candidate for a lumpectomy and radiation therapy. Remember, the radiation at the end of the day is used to mop up or clean the surrounding tissue after removing the primary tumor with surgery. So it's another reason why it's helpful to have a tool or a test, perhaps like the Oncotype test we discussed, that can help people decide when radiation isn't going to be of unique value so that you protect their options in the future, particularly if these are young women or younger women. There's another question that came in. That question asks, do you see any difference in patients with invasive cancer that had DCIS? And I think if I understand the questioner correctly, perhaps they're asking are the tumors higher grade, are they more aggressive, are they more worrisome? And the answer is not. I don't think we can say that the tumors are necessarily any worse or any better if they were preceded by a remote DCIS event, whether they were preceded by a proximate, meaning in the last year or two event, or whether they actually coexist. More important, again, is the unique biology of the invasive disease. And in order to understand the unique biology of invasive disease, that's where, again, gene expression testing may be of some value. Certainly for those individuals who have hormone receptor positive disease, considering the Oncotype test For invasive disease, which is a different but similar test, a decision may be made as to whether or not the biology is particularly aggressive, what the likelihood is of recurrence at a distant site in the body in 10 years, and whether or not there's likely to be a great value to the addition of chemotherapy. But these things really, again, depend upon many, many details. But ultimately, it's the biology that trumps all. It's the biology of the tumor. And it's not whether or not there was coexisting or a precedent DCIS. Now, we have another question that came in just a few moments ago that stated, what can I do to prevent recurrence after DCIS other than mammography? Well, of course, mammography doesn't really prevent recurrence. What does prevent recurrence is consideration of radiation therapy when recurrence risk is elevated enough to indicate a worthwhile benefit. And there's always some benefit of radiation, I suppose you can consider, but the question is, again, worthwhile benefit. Is the risk reduction enough to justify the impact of radiation in other areas? However, those individuals who have had DCIS should have mammography on a more frequent basis for the first couple of years, and many recommend, and in my own practice, I get mammograms at 6-month intervals in the operated breast for the first 2 years after the initial surgery. First 6 months is a baseline, and then for the next couple of 6-month periods to look for any evidence of early recurrence or evolution so that we can intervene quickly if there's a problem. However, when you talk about prevention, the term prevention implies preventing new disease, not a recurrence. Well, of course, as I mentioned to you earlier, tamoxifen is an agent that can be very useful in preventing or diminishing recurrence of DCIS. But what's really interesting about tamoxifen is it is one of the few drugs that has been approved by the FDA for use in women who are healthy. In fact, it's the only cancer drug that's been approved for healthy women with breast cancer risk, but who don't actually have breast cancer. And it reduces risk by about half. So for an individual who has had DCIS, and who has DCIS that does have hormone receptors, the use of tamoxifen not only reduces her risk of recurrence of that disease that was removed in the couple of years after the disease was removed, but it actually reduces her risk, which is of course higher because of her prior breast cancer, of a new breast cancer, not only in the same breast, but in the opposite breast. In fact, when we give tamoxifen to women who've had DCIS, only half of the reason we give it to them is for reduction in recurrence risk of their current DCIS. The other half of the reason we give it is, in fact, to prevent new breast cancer developing down the line. So, I see here somebody writes in and asks, is breast MRI recommended as a means of checkup or diagnosis after lumpectomy and radiation for stage 0 DCIS breast cancer? And this individual, who is from Dix Hills, New York, asks a good question. First of all, she's clearly attuned to the staging system because she understands that DCIS as a non-invasive cancer is indeed stage 0. It's not stage 1 or 2, so that's good. So it's stage 0 disease. And what about the value of MRI? Well, different physicians have different beliefs. There have been a number of important editorials written by leaders in my specialty, in surgical oncology and breast surgery, recognizing that MRI is probably, like PET scanning, a very, very overutilized tool in the management of patients with breast disease, both invasive and non-invasive. However, women with very dense breasts, women at high risk who are young, particularly those women who are under 40, MRI may be the only tool that is very helpful in identifying either new disease, recurrence of disease, or evolution of disease. MRI also can provide information on extent of disease. So MRI is generally a very sensitive tool, although perhaps not so sensitive for low-grade, low-risk DCIS as it is for higher grade or higher risk DCIS. And MRI may be useful in individuals with very dense breasts or with scattered calcifications that may be concerning but not clearly suspicious in trying to assess whether a woman has localized disease if she's just presented with DCIS, or whether she may in fact have multicentric disease with other areas of cancer elsewhere in her breast. So MRI certainly has a role, but we have to also keep in mind that MRI tends to be much more sensitive than specific, raises a lot of flags, and those flags often lead to interventions that can be, again, costly in effort, in discomfort, and of course in money to individuals. So I think that we need to use the test carefully in individuals at greatest risk where traditional mammography is not helpful or not sufficiently useful in helping us make clear recommendations. One of the other questions that was asked to me is, in your opinion, what is the one most important action a DCIS survivor can take or maintain in her daily life to reduce her risk of recurrence immediately after the 5-year tamoxifen treatment? Unfortunately, I can't give you one simple answer to this. What I can tell you is that all of the data thus far from the evaluation of large clinical trials worldwide in invasive and non-invasive disease of breast cancer treated with tamoxifen suggests that there's actually a carryover effect of tamoxifen, so that while we stop recommending women take tamoxifen at 5 years, the benefit of tamoxifen appears to last for 5 more years, at least after the tamoxifen is no longer given when it was given for 5 years. Some might ask, why do we in fact stop tamoxifen at all? Why not continue it? And of course, one of the reasons we stopped tamoxifen is a large study, an outgrowth of the study that ultimately led to the approval of tamoxifen in the United States, that was done by the NSABP, showed that women who took 5 years of treatment of tamoxifen and who were randomly assigned with their consent to either take another 5 years or stop and take a placebo, actually had no benefit from the additional use of tamoxifen. And on a numeric basis, they did worse when they continued tamoxifen than when they were switched to a placebo. How can this be? Well, tamoxifen is a little bit as a hormonal drug like a blank key. And imagine that the receptor to the estrogen receptor is a bit like an ignition switch on the cell. And if we stick a blank key into that ignition switch, it won't turn the key or the switch, but it will in fact block the ignition switch from the correct key that it comes along, which in this case would be estrogen. Unfortunately, in some circumstances, I suppose, if you wiggle the blank key enough, it may in fact turn the switch. And tamoxifen does that in some tissues right from the very beginning. The lining of the uterus, the bones. One of the reasons why tamoxifen actually has some bone protective effect, but also slightly increases the risk of proliferative problems or growth problems in the lining of the uterus, and even a small risk of uterine cancer. On the other hand, we believe that over time, the number of receptor sites that actually see tamoxifen as an agonist or as a proper key that can turn the switch increases. And the tipping point is somewhere around 5 years. So as a result, tamoxifen is recommended for only 5 years at this point in time. That is not necessarily true for the other class of hormonally active drugs, the aromatase inhibitors. These drugs, which go by brand names like Arimidex or Femara or any of the other aromatase inhibitors, these drugs actually function because they essentially get rid of the locksmith. So there are no keys being made. There is no estrogen being made. They only work in postmenopausal women. although there is a good question as to whether or not they are effective in DCIS. The results of large randomized studies are not yet mature to answer that question, but we would believe that they should be effective enough that for those women who absolutely cannot take tamoxifen because of family history of blood clots or because of other issues, the aromatase inhibitors may be an alternative, particularly if they're postmenopausal. So I think I've covered most of the questions that have been asked in advance and the questions that have come in during our conversation this afternoon. I hope that this session has been useful for you. As I said before, our goals nowadays are increasingly to personalize care, to pick the right treatment for the patient and to do it in a rational fashion. All treatments have risks, and all of the decisions have risks, but we learn to live with those in so many other parts of our life. In breast cancer management, whether it's invasive or non-invasive disease, the best that we can do is to facilitate dialogue between clinicians and between patients regarding the risks and the benefits, and ultimately help individuals navigate the correct path that will help them select what's right for them. I hope this has been helpful, and I thank you very much for letting me into your lives, and I thank you for the opportunity to speak today. Have a good day.
This concludes today's program. We would like to thank you again for participating, and many thanks to Dr. Hyams for making this web chat possible. As we mentioned earlier, this program will be available on our on-demand section here in the community so that you can visit it again or share it with others. Thank you.